Hey everybody, how we doing? Mike Biamonte, FBI School of Operational Medicine. How are you? This is video number 15. This will be the last video in, I guess, 4-part series of cardiology. We did cardiology A and P, we did cardiology diseases, we did treatments. Now we're going to get into the last piece, and we can talk about cardiology forever. We'll do what we call an advanced cardiac life support review. Now, let me make this very, very clear. I am not a representative of the American Heart Association when I'm making this video. Nothing on here is from the American Heart Association. This is not considered to be a refresher of ACLS, and in no way, shape, or form is it going to give you a certification card out of this. There's a disclaimer. This is just going to go over what most pre-hospital protocols are based on. And most pre-hospital protocols for cardiac arrest are based on the American Heart Association guidelines. So there it is. This is just going to go over, in general terms, the care for somebody who's in cardiac arrest or is really, really sick and trying to go into cardiac arrest. We alluded to some of that last video in acute coronary syndrome, somebody having a heart attack. And again, as a matter of semantics and terminology, you can be having a heart attack, but not going to cardiac arrest. Cardiac arrest is sometimes the end result of a heart attack. So here is somebody who is trying to go into cardiac arrest, or they're in cardiac arrest, and how we treat them. Now, the vast majority of what we're going to talk about is going to be at the advanced level. So just as a spoiler alert, for the basic providers that are watching this, it's good information. So I encourage you to watch it. You'll still get CEs for it, but it's going to give you a bit more of a peek behind the curtain as to what's going through the paramedic's mind, even the physician's mind in an emergency room. They're going to do the same things we're going to do in the field and vice versa to a certain degree. Now, obviously, in hospital, they're going to take it to the umpteenth degree and be able to have a lot more resources than we would have. But for the most part, in the initial phases of cardiac arrest, it's all the same. I don't care if you have MD at the end of your name or paramedic. We're going to do the same exact things. So that's what we're going to talk about in this video. Shout out, Honolulu. We were out there a while ago for work. Tough gig. We'll just say that. But beautiful. Goes this without saying. Gorgeous out there. So when it comes to cardiac arrest, we're going to talk about different kinds of care from basic CPR all the way to pharmacology and electrical treatment.
Should call an ambulance.
Look, you get the pills. Don't worry, I know CPR.
I'll get the pills.
Out with the battery. Out with the battery. This is a lot easier if you just lay back. He's resisting me. Here we go. Pills. Okay. Pills are good. Pills are good.
Now that obviously is not the way we're going to do it, but let's get into it. So when we look at somebody in the ACLS world, or advanced cardiac life support world, it doesn't have to be complicated. It really doesn't. Depending on how you look at it, you can really get caught up in this, and it's not hard. It goes back to the basic principles of patient assessment that we talked about before. Your patient's either sick or not sick. All right? If they're not sick, well, you have time on your hands. So if you're looking at somebody who's not sick, well, now you have to figure out, is their pulse rate fast or slow? And then you get into your assessment from there, and we'll talk about that. Wow. I don't know if you heard that or not. That was my wife. If you didn't hear it, my wife has the dubious honor and is recognized by my kids as being the world's loudest burper. So there it is. That's my wife. So I'm sure she'll kill me for that one, but you may have heard it was in the background. So it's either the dogs or my wife interrupting the videos. I did hide the bones. for this video. So now that I got off target here, If your patient's not sick and not desperately trying to die on you, there's questions you want to ask, right? Is their heart rate too fast or is it too slow? And then you want to know, is that heart rate wide or narrow? And again, we'll go down that road. If your patient is dead, all right, let's call it what it is. Your patient is without a pulse and not breathing. Well, quite frankly, this is easy. And I hate to say it this way. And again, I don't want to come across as too unfeeling and too callous. But don't make their emergency your emergency. Okay? A cardiac arrest is easy. They're already dead. As long as you didn't put them there or you weren't the cause of it, don't stress out about it. Go through the motions. Do what you have to do. Give them your best effort. Give them 110%. To try to revive them. But don't panic. Keep you calm. Because if they are in cardiac arrest, they can only be in 4 rhythms and 2 algorithms, as we're going to see here in a minute. They can only be in VFib, pulseless V-tach, PEA, asystole. That's it. And ironically enough, those are the 2 algorithms that they can fall into. VFib, V-tach, PEA, asystole. What is the first thing you do with these patients? High quality CPR. It all comes down to that. So for the BLS providers in the room, you're actually doing the most good. Quite frankly, and this is disturbing on a number of different levels, but a lot of the things that I'm going to talk about in this video, especially the pharmacology piece, they don't know if it really works, quite frankly, which is scary. The epinephrine, the amio, the lidocaine, the atropine, all the drugs that we may give, and we'll talk a little bit about in this video, they may not work in cardiac arrest. It's a hey, let's give it a shot and see what happens kind of a scenario, which is scary. It really is, but that's the truth of it. But we know CPR works. We know electricity works. So these are the big things we're going to talk about. So for the BLS providers in the room, if you feel a little left out, like, well, they're talking about all this advanced stuff during, cardiac arrest with drugs and CPR, good quality, hard, strong CPR. That's what's going to save them, quite frankly. Everything else we're doing is just icing on the cake, but you're doing the most important part. It doesn't have to be the BLS provider doing the CPR either. I'm just saying as an example. So let me go ahead and let's dive into it. So let's talk about the patient in cardiac arrest. Let's talk about that patient. Unconscious, unresponsive. You walk up, there is no pulse. You start doing CPR, and you start doing your thing. Your thing is your assessment. All right. What you want to know is, are they in a shockable rhythm or a non-shockable rhythm? Okay. Hollywood is going to tell you that everything gets shocked. Right? Patient's in a systole. Systole is flatline. All right. Systole is stable. They're not getting any worse. They may not be getting any better either. So you may even look at that as the most stable rhythm that's out there, because that is good and dead if they're in asystole. So asystole, PEA are your non-shockable rhythms. The only 2 rhythms that you're shocking is VFib and pulseless V-tach. That's really it. So your patient's unconscious, unresponsive, pulseless, apneic, not breathing. You start CPR. Good. Okay. Let me go ahead and put this up here. And what I want to show you first are the H's and T's. All right? These are your potential underlying causes. Now, I put this first because we're going to see this at the end of each algorithm in cardiac arrest. We're going to look at possible underlying causes. So your H's and T's can be a little confusing and daunting sometimes. Talk to T's, tablets and hydrogen ions and what the hell. What I'm showing you here is something that I was taught years ago, and it's worked very well for me over the years. It's match times 5 ED. Another medical, memory jogger, another mnemonic to get you through a stressful situation. You're working your way through your cardiac arrest. You're not having the results that you want, and you're looking to see what else we can do to maybe bring this patient back and get return to spontaneous circulation or ROSC. So M is MI. Maybe they're having a huge heart attack. And let's take some of these things into perspective and look at them realistically. Pre-hospitally, which is where we live and breathe, what are we going to do for somebody if they've had a massive heart attack and now they're in cardiac arrest? there's nothing we can do for that MI, quite frankly, except obviously get them to the hospital. Acidosis. Maybe they're acidotic. We talked about metabolic and respiratory acidosis and pathophysiology. So in this scenario, good CPR, oxygenation, some basic fluid management, it's all we can do for acidosis. And if you have somebody on end-tidal CO2 monitoring that we talked about in airway, you have them intubated, you put them on end-tidal CO2, you confirm that tube. If your end-tidal CO2 drops below 10 millimeters of mercury, even after a good period of solid resuscitative efforts, chances are that patient is dead. And then you get into termination protocols and whether you should transport that patient or not, but that's a protocol-based thing. But if they're acidotic, number one, how do you know? We don't. We don't do blood gases. We don't, we can't draw labs to that extent, at least in most systems, to be able to see if they're acidotic or not. If they are acidotic, could you give them some bicarb? Yeah, maybe. 1 milliequivalent per kilogram? Sure, give it a shot. Couldn't hurt. T, tension pneumo. Okay. I've had more than my share of patients that slipped into a tension pneumo because of the resuscitative efforts, because of the CPR, the Geezer squeezer, the Lucas device, the auto pulse. Right? Sometimes those fracture ribs and sometimes those create tension pneumos. Well, you got to decompress them. So maybe that's the underlying cause. Now, that in my scenario, that didn't put them into arrest. They were already in arrest. But if they're traumatic, think about it. C, cardiac tamponade. Maybe they've got fluid around their heart. And you'll see what's called Beck's triad. In your patients who are alive, you would see a narrowing pulse pressure, muffled heart tones, JVD. You're not going to see that in somebody who's in cardiac arrest. How would you know? You wouldn't. Pericardial centesis is the only thing we can do to treat that, and most EMS systems don't do that. Now your H's. I say that there's 5, right? Hyperkalemia. The potassium is either really, really low or really, really high based on why you found them. You'll see this sometimes in your dialysis patients, as an example. Of course, when it comes to trauma and electrocution and crush syndrome and things of this nature, sure, you can have some problems with your potassium, but think your post-dialysis patients as well. And some systems have protocols for that with calcium and sodium bicarb and so on. Hyperhypothermia, hyperhypoglycemia, hypovolemia, hypoxia. All right, the hypoxia we can definitely do something about. The hypovolemia, yeah, we can give them some fluids. The hypoglycemia, sure, we can give them fluids. Hyperhypothermia, warm them up, cool them down. Not much there. E is embolism, pulmonary embolism. Somebody has a big PE and they go into cardiac arrest. Boy, there's a really good chance they're not going to make it, unfortunately. And sometimes in these cardiac arrest patients, depending on the size of the embolism, you'll see this discoloration in their skin from nipple line up. They turn purple from the nipple line up. It's a real bizarre kind of a presentation. Doesn't always indicate PE, but sometimes that's what you'll see. And again, there's no way you would know necessarily that they would have a PE, and that's why they're in cardiac arrest. And D, drug overdose. What kind of drug? Who knows? Maybe you do know. Maybe it was a heroin overdose or an opioid overdose or X, Y, and Z overdose. And perhaps you've got a robust tox protocol to where you have certain countermeasures for certain overdoses, depending. So only if you know what kind of overdose they've really stepped into will you be able to treat that cardiac arrest based on what you think you know. So those are the 5 H's, 5 T's. Let me pull this down. Okay, and match times 5 ED, that's just something that I've taught over the years, and I was taught years ago, but it's just a good way in the middle of your cardiac arrest algorithm to really start getting your wheels turning. Remember, as I've said before, a good medical provider, you shouldn't be living in the moment. You should be living 10, 15 minutes in the future and thinking to yourself, all right, I've got CPR going, I've got a basic airway in place, I've got an IV established, all right, why? What, why, and what? What's happening? What are they complaining of, cardiac arrest? Why are they in cardiac arrest? And what can I do about it? And unfortunately, pre-hospitally, some of the things that we can do for cardiac arrest are fairly limited. It's all about time. How long have they been down? If you can get to somebody within 5 minutes, you got a good chance. And look at these numbers and think about these numbers for a second. For every 1 minute you're down in cardiac arrest without care, you suffer a 10% mortality. Okay, I'm no math major, but let's think about this for a second. Let's think about standard EMS system USA. Inner city versus rural. Inner city, you're typically going to get your response time a lot faster. If you're rural and you're living way out there and it takes fire EMS 10 minutes to get to your house, regardless of how lickety-split they come out of that bay, they come out of the firehouse or the station, 10 minutes is 10 minutes. So let's just say theoretically, knock on wood, I go into cardiac arrest right here. Right? My wife has no medical knowledge whatsoever. She calls 911, and let's say it takes them 10 minutes to get here. All right, for every 1 minute I'm in cardiac arrest, I suffer a 10% mortality. My chance of survival, 0. That's not EMS's fault. That's not fire department's fault. That's the system. That's Mother Nature. That's what we live in. So the quicker you can get to somebody with good CPR and an AED, the better the chances of survival, which is why there is such a robust campaign for CPR and AED management. So that's the basic side of the house. And that's really what it all comes down to. If we do nothing more than good CPR and basic airway management and AED care, automatic external defibrillator, we're doing everything we can do for the most part. So let's take a look at, let's see, I talked about that. Let's put that one up there. All right, let's get into this. Let me show you this slide. So here we have it. Here's your pulseless patient. So you can be a wizard, right? And you may appear as if you're a wizard. You're on a crew, you're the ALS provider, you roll up, your patient's in cardiac arrest, you feel for a pulse, there's no pulse, you turn to your crewmate and say, hey, let's go ahead, let's get CPR going, let's get the monitor on them, let's go ahead and prepare for defibrillation, but let's get 2 solid minutes of CPR in there. After we get that line, let's go ahead and get a milligram epinephrine prepped. You look like a damn rock star, right? Why do you look like a rock star? Because you got your shit together, you're calm, you're giving out orders, you're giving direction, and at the end of the day, that's what pulseless cardiac arrest, right, CPR and management is all about. The initial management is CPR, basic airway management, doesn't have to be advanced, okay, it just has to be effective. Put the monitor on, but 2 minutes of CPR. If it's an unwitnessed cardiac arrest, you physically did not see them go into cardiac arrest, give them 2 minutes of CPR. Hard, solid, strong CPR. And in that 2 minute time period, well, you've got time. Let's get their airway managed. Let's go ahead and drop an IV. Let's put the monitor on them. I don't care what that machine says after you put them on. You still have to finish 2 minutes of CPR. Okay. Now in that 2 minutes, you've got the airway in place. Again, doesn't have to be advanced, just effective. Well, now you stop and you do a pulse check or you do a rhythm check in that 2 minute period. And what you want to see, are they in a shockable rhythm or a non-shockable rhythm? That's really it. Only questions you have to ask. Well, if they're in a shockable rhythm, VFib or pulseless VTAC, all right, let's blast them. But don't wait. What I mean by don't wait is don't say, okay, let's hold off on CPR. No, CPR is the most important thing. Limited hands-off time. You want to blast that chest as much as you can. So while you're continuing CPR, you're going to charge up the machine. Now, here's the rule on biphasic versus monophasic, 120 joules versus 200. Here's my take on it. Pre-hospitally, I dare you to find a monophasic monitor anymore. They're pretty much all biphasic. And what that means is all you need then is a lower joule setting to do your thing. Follow your manufacturer's recommendation, whether it's Zoll, LifePak, Philips, doesn't matter. They all have a recommendation on joule setting, whether they want you to go stacked shocks, 120, 150, 200, or they want you to go to 200 and stay there. Doesn't matter, quite frankly. Follow your protocol. That's really what I'm telling you to do. But here, I'm showing 200. That's usually what I do. That's my thing. All right, I'm going to put it to 200 and stay there. It's just easier. It's one less thing for me to think about. So I'll blast them at 200. After you blast them, you do not check their pulse. Go right back into CPR. Start CPR again. That's the key to success of CPR. Well, now you got 2 minutes. Go get a cup of coffee. No, I mean, you're still doing your thing. But now you have that opportunity to take a step back. All right, let's think about what we're doing. We got CPR going. We got the airway taken care of. We've blasted them once. We know we're in a shockable rhythm. Okay, do we have an IV established yet or an IO established yet? Quite frankly, I don't screw around with IVs in cardiac arrest anymore. I go right to an IO, but that's just me personally. But now, if it's unwitnessed cardiac arrest, you're going to do another 2 minutes of CPR before you start thinking about drug therapy. And you're going to go ahead and blast them again at the end of that 2 minutes if they're still in a shockable rhythm. And what's the first drug out of the box? Epi. Guess what the first drug out of the box is for PEA asystole? Epi. So regardless, first drug you're pulling out of the box in any pulseless patient is epi. It's easy. The only addition now is after you give the epi and 2 minutes of CPR and shock and 2 minutes of CPR and shock, you're getting into that rhythm. Then you're looking at an antiarrhythmic drug. Amiodarone, I have listed here. You could also consider lidocaine, depending on your protocol. It's all protocol-based. Here I have amiodarone listed, 300 milligrams. If you have to repeat that after about 5 minutes, give or take, upwards of maybe 8 to 10 minutes, you're just going to cut the dose in half and give 150. But it's in a bolus. It's not in a drip. It's in an IV bolus. If you wanted to give lidocaine, 1 milligram per kilogram, 3 milligrams per kilogram is your max dose. But again, you're going to follow your local protocol. So let's just go back here real quick, VFib, VTAC. You walk up to a patient. They are pulseless. They are dead. Don't panic. Start CPR. Basic airway maneuvers. You're going to do at least 2 minutes of CPR because you did not witness this. You do CPR. You start bagging the patient. You go ahead, put them on a monitor. You get me set up for an IV. Again, this is depending how many people you have to help you. And go ahead and let's prep 1 milligram of epinephrine. You're a rock star because you know you're going to have to give epi regardless of what you see on that screen. The question now is going to be, are we going to shock this or not? So let me go ahead and change this screen. And let's look at PEA asystole. This one is easy, quite frankly. The only drug out of the box is epi. There is no shock. It's CPR, epi, and H's and T's. And the H's and T's obviously are a consideration in VFib, VTAC as well. But we woke up to our patient. They're in cardiac arrest. No pulse, no breathing. You start CPR. You start to manage the airway as best you can. You put them on a monitor, and you're doing 2 minutes of CPR. You're trying to get a line established. You're drawing up 1 milligram of epinephrine because that's what you're going to give regardless. And you're waiting. Now you find that they're in asystole PEA after the first 2 minutes of CPR. Well, there's not much you're going to do, quite frankly, other than evaluate the H's and T's, give epi every 5 minutes, give or take, and transport or don't transport. Depends on your protocol. If you've got a patient in asystole, you've got a good airway, you've got good CPR going on, you've gone through your H's and T's, you've gone through a few rounds of drugs, and their end-tidal CO2 isn't coming up above 10 millimeters of mercury, yeah, most protocols will tell you to leave them in place and don't transport. It depends on your protocol. You may have to call, you may not have to call. When I say call the ER and ask for permission. So that's a protocol thing. So let me go ahead and pull this down. So all we've talked about right now is your dead patient, essentially. That's it. Quite frankly, that's the easiest. I know it sounds cold and callous, but it's true. If you come up to a patient and they're in cardiac arrest, it's CPR, it's good airway management, you're putting a monitor on them, you're getting IV access, IO access, you're drawing up 1 milligram of epinephrine, and then they're either in a shockable rhythm or non-shockable. Right? The only addition to the shockable rhythm, other than shocking, of course, is amiodarone, 300 milligrams. If you have to repeat, it's 150. Your max dose on amiodarone is 2.2 grams in 24 hours. Dare I say, no ENS agency carries 2.2 grams on their truck, so don't worry about the max dose. That's your pulseless patient. It's pretty simple. Again, you walk up, they're pulseless. They can only be in 4 rhythms: VFib, VTach, PEA, asystole. PEA is pulseless electrical activity, by the way, for my BLS providers. Basically what that means is you're going to see an organized rhythm, what looks in some cases to be almost normal going across the screen, but there's no pulse. And that could be for a variety of reasons, and your H's and T's sometimes have a lot to do with that. But it's an ominous sign. If they're asystolic or in PEA, prognosis is typically pretty poor. If they're in VFib, VTach, you have some electricity to work with. So there's a glimmer of hope there. And when we talk about defibrillation and we talk about electrical therapy, we're going to get into that now a little bit more in the tachyarrhythmias. But when we talk about electrical therapy, what is it we're actually doing?
Throw the third switch!
Not the third switch.
Throw it, I say! Throw it! Lies! Lies, do you hear me? Give my creation life!
That was when I had hair. That was me years ago, black and white. I'm not that old. But with electrical therapy, all we're doing, if somebody's heart is in ventricular fibrillation or ventricular tachycardia, it's just kind of quivering. It's not doing anything. Now, you can be in VTach with a pulse, but that's another conversation we're going to have here in just a minute. But if you're in VFib, pulseless VTach, and we shock you with 200 joules, what we're doing is we are depolarizing every myocardial cell. Remember, in the last few videos, we talked about each myocardial cell being like a little battery. All individually, they charge themselves and they discharge and recharge. So they depolarize and repolarize. What we're doing when we're defibrillating is we are depolarizing every myocardial cell at the same time in the hopes that the SA node, sinoatrial node, is going to kick back in under its normal power and start doing its thing. We're rebooting the system for the IT people. All right? Your computer's screwing up. What does IT tell you to do? Reboot and let me know what happens. That's what we're doing. We're rebooting, but we're defibrillating when we do it. Another name for defibrillation is unsynchronized cardioversion. So that's just another name for it. You'll see that in some textbooks. What we're going to talk about here in just a minute with tachyarrhythmias with a pulse is synchronized cardioversion, and that's a little different. So let's start talking about your patient with a pulse. Now, you walk up to a patient and they don't feel well. Okay. Same questions apply. Are they sick or not sick? If they're not sick, well, you've got time on your hands. That's really what it comes down to. But if they're sick, you want to start moving with a purpose, and then you want to know a few things. Well, let's talk about the non-sick patient first. All right, so here we go and put this up. So you walk up to a patient. They have a pulse. Here's the questions you want to ask. Are they sick or not sick? And is their pulse rate fast or slow? Now, I'm not going to get into, is this SVT? Is this multifocal atrial tachycardia? Is this junctional tachycardia? Is this... No, I'm not going to get into the minutiae of that because it isn't necessary for your treatment. What you do want to know, if they're fast, okay, you may have to do nothing. And by fast, to treat a patient with a tachyarrhythmia, as it's called, they usually have to be about 150 to 160 or greater as far as a heart rate goes. That's a loose number, but that's sort of the number that we use. If they're 140, 150, maybe they're a little hypovolemic, maybe they're febrile, septic, maybe they're scared, maybe they're pissed off. So you don't have to start treating right away. What is the underlying cause of the tachycardia? But if they're tic-tacking away and they're fast, I mean, they're 180, 200, what you want to know is it wide or narrow? And what I mean by that is, are your QRSs wide or narrow? So for the ALS providers, your QRS should be no more than 0.12 seconds as far as width, or 3 small boxes on your EKG strip. It doesn't matter, truth be told, wide or narrow, because if they're not sick, you got time on your hands. Okay, yeah, they're really, really fast, they're really narrow, they're really wide. Wide is worse than narrow in the grand scheme of things when we talk about EKG interpretation. But your treatment's going to be the same: adenosine and amiodarone. Or, again, follow your local protocol. Maybe lidocaine is in there or something else. Adenosine. For either one, if they're, and when I say not sick, if they're asymptomatic and tacking away, all right, again, you may choose to do nothing. That's a gut check on your part. But if they're not sick and very, very fast, above 160, think 10 minutes ahead, think 15 minutes ahead. Okay, they're stable now. How long are they going to be able to stay that way? Let me mitigate the situation now before they get any worse. So adenosine may be the right answer. Remember, with adenosine or Adenocard, 6 milligram rapid IV push followed up right behind it with a 10 cc flush. Right behind it. You want to start that IV very proximal, very close to the heart, right? EJ, AC, so you really want that thing close. And you want a large bore IV, 18 or better. You want to get that flow, because your adenosine only has a half-life of about 30 seconds. So if you start that IV with a little tiny 22 gauge in the hand and you try and push it, that drug is going to be biotransformed and broken down before it ever reaches the heart. It's going to be completely ineffective. 6 milligrams to start and 12 milligrams as a follow-up. That's your standard protocol. It may work, it may not. Sometimes it works like a charm. Other times, not so much. It'll be moderately effective, but then it'll come right back. That's just the nature of the beast, and that depends on what really is going on. Is it truly a reentry phenomenon? Then you get more deeper into cardiology. But try the adenosine, see if it works. You may have what looks like a wide complex tachycardia, but it's actually narrow. Sometimes it's hard. You may have what's called tachycardia with aberrancy, so it just depends on how the electricity is conducted through the heart, how the machine interprets it. All that to say, start with adenosine. Adenosine, if it is given to a patient in a wide complex tachycardia, it's not going to hurt them. If you give it to them in a narrow complex tachycardia, it's not going to hurt them. The nice thing about amiodarone is the same rule applies. If you give it to your narrow complex tachycardia or your wide complex tachycardia, no harm, no foul. It's not going to hurt them. Lidocaine is a little different. Lidocaine is only given for your wide complex tachycardias, not your narrow. That's the big difference there. So your amiodarone is not given in this scenario in your pulse-producing tachycardias. Your amiodarone is not given the same way you would give it in cardiac arrest. In cardiac arrest, you're giving a 300 milligram bolus. And if you have to repeat it, it's a 150 milligram bolus. Here, you're giving 150 milligrams mixed into 100 cc's. Typically, it's a D5W solution if you have it, but normal saline will work. You're pushing 150 milligrams of amiodarone into a 100 cc bag at D5W, and you're infusing it over about 10 minutes. So it's a slower process. You just got to be careful with hypotension in these cases. Amiodarone, if you give it too fast, sometimes they'll have a little hypotension. So just be aware of that. That's your tachyarrhythmia that's stable. Right? They're not sick. All right. They're really, really fast. Are they wide or are they narrow? Doesn't matter. Your treatment is exactly the same. Adenosine, amiodarone, or in some systems, lidocaine. What if they're too slow? Again, I don't mean stupid, but what if they're too slow? It could be totally normal. Think about your extreme athletes, your people who are physically fit as a fiddle. They're sitting there drinking a cup of espresso and their heart rate is 32. It's incredible. I don't know how they do it. I'd be dead. Normal heart rate, 60 to 100. So anything below 60 is considered bradycardia, but it doesn't mean they're sick. I've had extreme athletes in their high 20s, low 30s, and they're awake and fine and doing everything they're supposed to do. I had a little old lady years ago. She, I think she was 85 or something like that. Nursing home was losing their mind because her heart rate was like 26. But she was warm, dry, mentating, good blood pressure, everything. Did I blow her off and not transport her? No, absolutely not. I took her to the hospital. I started an IV. I had her on the monitor. I watched her like a hawk. We had a very nice conversation. She was very happy to be out, some fresh air. We were chit-chatting the whole way, right? So there was no reason for me to do anything with her because she wasn't sick. But you may have patients who are in that gray area, and it's that gray area that sometimes is troubling. Okay, they're slow. They're not really sick, but they're getting sick. Okay, let me do something to speed their heart rate up. Atropine. Right, we talked about atropine in pharmacology review. Atropine, rapid IV push, 0.5 to 1 milligram. You don't want to go less than 0.5 in an adult, and you don't want to push it slowly. You don't want to increase the bradycardia. Well, let me rephrase that. You don't want to make the bradycardia worse, and that's what you can do if you push it too slow or give less than 0.5 milligrams to an adult. So rapid IV push, atropine, up to 3 milligrams, max dose, total. It may work, it may not. If it doesn't work, all right, maybe you can go to dopamine and try some dopamine at a lower dose, maybe 5 mics, and let that run in. But again, it depends on your protocol, depends on your patient status. So that's your pulse-producing fast patient, pulse-producing slow patient. Easy treatments. But the nice thing about these patients is you have time because they're not dying. They're not trying to die on you right this minute. However, they could. So let me change the slide and put this one up here. Now, same category, right? Pulse-producing patient. Sick or not sick? Are they fast or slow? Right, well, now we're in our sick category. This patient is trying to die on you. All right, well, they're trying to die on you and they're fast. I'll pick on New York City Fire Department a little bit. This is when they first started running EMS. I was there at the time when the merger took place and New York City EMS transitioned into New York City Fire and EMS, which was a very, very tough time in the city. I was lucky I worked for the voluntary. They called them the voluntaries at the time. It was New York City EMS, but we were paid by the hospitals versus being paid by the city. So that and $2 will get you a cup of coffee. But what we found was when New York City Fire Department started running EMS calls with us, they were a little rusty. They weren't good at EMS. Best firefighters in the world. But at the time, their fire side of the fire department, the EMS piece of being a fireman, their skills weren't very highly tuned. So I remember coming up and firemen were standing at the door saying, "Hey, come on, hurry up. She doesn't have a pulse." So, oh, shit, she must be dead. So we come walking into the living room. There's 5 firemen standing there, and there's a woman laying on the couch, and she's looking right at me. I said, "Where's the patient?" They said, "She's right there." I said, "She doesn't have a pulse?" They said, "No." And she's looking at me with this panicked look on her face. I said, "Guys, here's a little tip for you. If she's looking at you and talking to you, she has a pulse somewhere. You just might not be able to feel it." Well, of course, they looked at me like I was an asshole, and I was. I am to a certain degree, but what are you going to do? But yeah, I reached over to grab her pulse, and yes, they were right. She had no radial pulse. But that was because it was going so fast that you couldn't feel it. And she was hypotensive, so she was a sick patient. So let's talk about the fast sick patient for a second. Again, same rules apply. Is it wide or is it narrow? And at the end of the day, I don't care whether it's wide or narrow. They're sick, they're fast, they need electricity. That's what they need.
Close, but definitely wrong. Okay.
Now, it's much more painful for the patient when you synchronize cardiovert them, to say the least. Do you have to sedate your patient before you synchronize cardiovert them? No, you don't have to. If they're really trying to die on you, blast away. So what is synchronized cardioversion? So here's your patient. They are really, really fast. Hypotensive, cool, pale, diaphoretic, altered mental status, chest pain, difficulty breathing, whatever labels you want to put on them. they're sick and they're trying to die on you. All right, you don't need an IV to do this. You don't need anything to do this. All you got to do is slap the pads on this patient, hit the sync button, all right, synchronized cardioversion. And what you're doing when you hit the sync button, SYNC, on the monitor, is you're then allowing the computer on the machine to deliver that electricity right on the R wave. What that does then is it alleviates the potential for you to create what's called an R on T phenomenon. If you deliver electricity on the downslope of the T wave, which is what we saw as the relative refractory period in a prior video, what you could do is you could put that patient into VFib, VTAC, and you could kill them. So you don't want that responsibility on your hands. So what you want to do is you want to give the responsibility of timing of synchronization to the machine. Once you hit the sync button, you'll see flags across all the R waves. You'll see these little dots, these little triangles. That's how you know you're in sync mode. Charge it up to 100 joules and hit the button. Blast away. Call clear, of course. You don't want to hurt anybody else. But call clear. This is synchronized cardioversion. And the machine will deliver that electricity at the exact right moment to reboot the heart. And it hurts like a son of a bitch. Right? Patients are not happy with you when you do this because they are conscious and they know what's going on. So depending on timing, depending on manpower, depending on resources, you can sedate them with some Versed. It's a good idea. At least 3 milligrams. Nice thing about Versed, they don't remember what you're doing to them. So they'll scream at you. You'll charge up, and blammo, you'll hit them. You son of a bitch! They'll come up off the bed. And then they go back asleep again. And hours later, if you follow up with them in the ER and you say hello to them, they're just going to complain that their chest hurts because you blasted them, but they don't know what you did to them, which is kind of nice. So wide or narrow, as far as tachycardias go, it doesn't matter. On here, you can see in your narrow, you can go from a range of 50 to 100 joules to start. And typically it goes 100, 200, 300, 360 as far as your stacking goes, repeat cardioversions. Just start at 100. Again, follow your protocol, but just start at 100. What difference does it make, 50 to 100? Blast away. So if they're sick and fast, over 160, synchronized cardioversion. If they're slow and sick and trying to die on you, I don't care if it's sinus bradycardia, 3rd degree heart block, 2nd degree type 2, means nothing to me. It means nothing to the patient. They're slow and they're really, really sick. Transcutaneous pacing. Pace them. That's the right answer. After that, then you can consider dopamine or epitrips or that sort of thing. But transcutaneous pacing is very, very effective and works very well. Follow your protocol on that. So bottom line, patient with a pulse and they are sick and trying to die on you and they're too fast or too slow, electricity. That's really it in a nutshell. So let me go ahead and pull this down. Let's do a quick recap here of what we talked about. Let's also remember what your monitor can do. Your monitor defibrillator. What can it do? Your monitor defibrillator will monitor your heart rate. Doesn't tell you anything about a pulse. All right, it's all electrical. It's monitoring your electrical activity in your heart. So your heart, it's going to monitor your heart rate and rhythm. It's going to defibrillate you or unsynchronized cardiovert. It's going to defibrillate you if you are dead. It's going to synchronize cardiovert you if you are too fast. And it's going to pace you if you are too slow. That's what that machine can do. It does it very well in the hands of someone who knows how to use it. That's what it does. So you come up upon your patient, and they are dead, pulseless, apneic. No problem. They can only be in 4 rhythms: VFib, VTAC, PEA asystole. First drug out of the box, epi. Easy. Start CPR, manage the airway. 2 minutes of good solid CPR if it's unwitnessed. If it's witnessed, you see it happen right in front of you. Same thing, CPR right away. But you want to defibrillate them as fast as you can if it's a shockable rhythm, which usually it is if you see them go down right in front of you. But good quality CPR, good airway management, good solid 2 minutes of CPR. If they're in VFib, VTAC, you shock at 200 joules, CPR. Epi 1 milligram, Q3 to 5, shock, CPR. Amiodarone 300 milligrams, shock, CPR. It's very cyclic and very spaced out. Easy. They're in PEA asystole, well, same rules apply. CPR, good ventilation, IV access, 2 minutes of CPR, epi, epi, epi. Boring. PEA asystole is a boring cardiac arrest. At the end of both of them, H's and T's. Try to see what you can reverse, if anything at all. And give it a shot if you have the protocol to do it. So now we have a pulse-producing patient, somebody who is stable, but they're fast. All right. Maybe give some adenosine, 6 and 12. That doesn't work. Try some amiodarone, 150 milligrams and 100 cc's over 10 minutes. All right? What if it's wide versus narrow? Same thing. Adenosine, amiodarone. All right. What if it's slow, but they're not too sick? Borderline sick. Gray area sick. Atropine, 0.5 to 1 milligram. Okay. You got time on your hands. Don't worry about it. Maybe they're fluid sensitive. Give them a fluid bolus. Maybe they're hypoxic. Give them some O2. All right. Go through your H's and T's again. Some of those apply. What if they're sick and they're fast? I don't care if it's wide or narrow. Sick and fast, synchronized cardiovert. Blast them. So just hit that sync button, hit them at 100 joules. Okay. Do you have to sedate? No, you don't have to, but it would be nice if you could. But I wouldn't waste any time doing it. Or if they're slow and sick, pace them. Electricity is your friend. Right? Let electricity work for you. You don't need IVs. It's a very rapid kind of a procedure because you don't need much in the way of IVs or anything else. You can just get right to it. So that's ACLS in a nutshell. Let me make sure I covered everything here. Wide, narrow, fast, slow. That's really it. That's all there is to ACLS. It doesn't have to be that complicated. It really doesn't. At the end of the day, follow your local protocol. This is not a refresher for the American Heart Association. Please don't think it is. This is just me summarizing advanced cardiac life support care based on the vast majority of protocols that are out there. And every protocol is going to be tweaked a little bit based on your medical director. So that's obviously what you're going to follow. But that's as difficult as it has to be. It really doesn't have to be very hard. So I think that's it for cardiology. We've covered most of the bases. For my FBI personnel, code word. Code word. Oh. I'm at a loss. Lost. Yeah, there we go. Lost. That's the story of my life. L-O-S-T. Lost. There we go. That's our code word. Lost. She's mad at me. So that's not the story of your life. All right, gang. I think that's it. I'm right at about 45 minutes here. Had a good time again, as always. Enjoying it. Hope you keep on tuning in. We'll see what the next one is going to be. I'm not 100% sure, but we'll put it out shortly. Have a great day. Stay good.